Welcome to Let's Talk Care, a podcast about research and quality of life in long-term care homes in Canada. I'm Marco Redden, joined by my co-hosts Mary Jean Handy and Emily Hubley. Each episode, we'll look at a different piece of the long-term care puzzle and share fresh perspectives as early career researchers navigating the field.
Welcome back to the podcast. We're on episode number 6 now, and this is going to be a podcast focused on dementia. And today we are joined by Faye Forbes and Jim Mann, both of the Salty Advisory Group. So maybe I'll get you guys to introduce yourself first, a bit about who you are. Jim, I know you've been on an episode previously, but Faye, I believe this is your first. So maybe just great who you are and some of your experiences working on the Salty Advisory Group. So Faye, I'll have you go first and then Jim.
Well, my name is Faye Forbes and I live just outside of Halifax in a little tiny community. And really enjoy it out here because it's city, but it's country as well. And I was diagnosed with early stage dementia, Alzheimer's in particular, a little over 11 years ago now. And I joined the Salty Advisory Group from the onset. So I'm one of the original members. Wow. And it has been such an eye-opening and learning experience for me, being on that advisory group, as well as going through the journey of dementia has been eye-opening and a learning experience almost on a daily basis. And I mean, there's good days and there's bad days. And the advisory group I found was not only supportive to the researchers and the paper writers and everything, but also a support for the people on that team. So I was sorry to see it come to an end, but we've learned a lot and we've got a lot of experience to help others form their own advisory groups now.
Yeah,
that's very true. Cool. Jim, what about you?
I'm Jim Mann on the West Coast in the Vancouver area, and I have Alzheimer's, and I was just counting. I think it was 14 years ago in February that I was first diagnosed, I was a member of the Salty Advisory Group as well, and from the early start. And I look at our experience positively and as really a role model for other advisory groups, because of the credibility assigned to the advisory group by the researchers, and it was illustrated by our periodic meetings with researchers, various streams, and they would make a presentation, ask for our input, and that to me showed a validation of the concept and also a positive feeling that we were being viewed as credible, as people who were able to provide the guidance for the project.
Yeah, that's really cool. What do you think are some of the things about how the advisory board was run or your experiences during it that sort of contributed to that feeling like it was a good role model for future projects?
Can you try that again, Marco? I'm sorry.
Oh, no problem at all. Just you were saying that you felt like the way that the advisory board was run, that it was, you felt that your experience was validated and that it was, the way they ran it was a good role model for future research projects. And I was wondering if you could speak to, what were the features about how the project ran and how your experience was, like what were the features of the advisory board and how it was run that made you feel like it was a good role model for future projects?
The composition of the advisory group was a good one in that it had a full-time care provider, paid care provider, care aide. It had two of us with dementia, maybe three. I can't remember.
There was about 4 with dementia.
Oh, okay, 4. And care, unpaid family caregivers and so on, so that you had a good cross section of people that all had a sort of a stake in the outcome, if you will.
Right.
And that was a good start.
Yeah.
And there was from the beginning, the whole team, the whole research team and the advisory group met for a face-to-face meeting and group dinner and so on. And again, that established that we were here. We were part of the team. And I think really in some ways, those were the great foundation building on which you built the rest of the subsequent activities for the Salty project.
Yeah. That
So if I can just add something to that, we did have a variety of people on the advisory group. We had family members that had loved ones in long-term care. We also had a person in long-term care on the group.
Yes, that's right.
And she was delightful and very insightful about things that we didn't ourselves experience. And when we first came together, we met as an advisory group first, and then it was like 12 people or 14 people, I forget how many, that never knew each other, had never come together. And we had to find some commonality between us other than dementia. And we had to build up that relationship and trust. And it wasn't long after that we went out to dinner with the research leads and the co-leads and everything. And some of them had never worked with an advisory group before, so they didn't know what to do with us. But that social aspect that we would have in meeting with the researchers and the advisors and everything built up that relationship and that trust. And then they felt free to come to us with a question or ask our opinions or work with them on a paper or whatever it happened to be. And that was the start. Now, every time we got together, it was a learning session because we were going into unknown territory.
Yeah.
And
absolutely.
Yeah, we made a few wrong turns and we did a few detours, but it all worked out in the end. And we found better ways of doing things.
Yeah.
And now we're ready to share that knowledge with others.
And you can feel confident that it's, you think of academic research as in sort of the historical sense as this, this ivory tower, and it's, people who don't necessarily have much experience in the day-to-day world about what they're researching, trying to, put out their expert opinions, but now we're into a mode where we're bringing the people that it's relevant to into the process. And I think, it sounds like both of you feel like it's a more valuable product.
You could consider us a research project.
Absolutely, yeah.
Yeah, just as a research assistant on the project, coming in about halfway through and being introduced to this, it felt like this whole new world. It was a huge project with so many people, and just at every meeting, having the advisory group and different people in different roles add their experience or ask their questions. I know like you guys might have questioned your role and if you were contributing, but just being a bystander and watching and hearing you ask those questions, you really did make us think about what we're doing and what we could be doing better.
Mm-hmm. Mm-hmm.
Well, thank you for that.
Oh, no problem. So I guess that's
that was the question that always came up at least once a year. Is our role worthwhile? Because we didn't always meet with the researchers and the leads and the co-leads. A lot of it was done through email or phone conferences and stuff like that. So we probably only met as a full team once a year.
Yeah.
And during the rest of the time, we'd say, are we doing something worthwhile? Is it meaningful? And the answer that we all came up with is, if we feel satisfied with what we've done, then yes, it's meaningful to us. So then we can go back to the researchers and say, are you satisfied with what has been accomplished with us? And if they said yes, bonus.
Everyone's happy.
But if they said no, then we would work together on how we could improve it.
Yeah, I remember there's a few instances once at the full team meeting in Halifax where our long-term care resident on the advisory group, she mentioned you can make the long-term care home-like, but it will never be my home. And that was kind of one of those aha moments for, I think, the whole team and many researchers. Like, we're always working to make it someone's home, but that's not how maybe they view it. Maybe not all, but some. And I remember, Jim, at one of our meetings, you brought up the idea how ethics boards and all these processes make it so difficult to include people with dementia in research, like either as part of the team or as participants, and how if it's so hard to do this and we're not doing this, then what are we learning if we can't, have them be a part of it? So those were just some of my takeaways that I had from the advisory group.
Yeah,
that's excellent.
It's so important to hear the lived experience from all the different sides of it, because dementia not only affects me, but my family and my coworkers and everybody else that's in my life. And that's what we had on the advisory group, a variety of people.
And experiences.
Exactly. And that's what counts, is bringing our experiences to light.
Because the one thing that in our case researchers will bring to the table is their preconceived notions of people with dementia or the residents of long-term care. And from that then will come that automatic assumption that we will not be able to get what we need from the resident, relevant information from the resident. So we just know that we will be going to the family or the friend caregiver for this information. And I'll say fight that tooth and nail, but I did discuss that and did, I think, influence some decisions, because there are ways to communicate with people with dementia, or in later stages, whether it's verbally or through what I always talk about is talking mats that I learned about from the UK. And so there are ways to get information, because many papers have talked about the variance of opinion from the caregiver versus the resident, or the person with dementia or whatever, that their view of the world will be diametrically opposed in some cases. And so that for me is the relevance and the importance of an advisory group.
What I take away from your comments, Jim, is that not only that there are ways to communicate with people in the later stages for research purposes, but that person is still the same person that they were.
Yeah.
They just can't get the words out or put the thoughts in order or whatever it happens to be. So it's not so much the questions you ask, it's how you ask the questions.
Yeah, that's a great point. And us as researchers need to maybe step outside of our one way of thinking and asking questions and doing research and accommodate other people to get their experiences.
Yeah, come out of your silo like Rapunzel and crawl down into the real world.
Yeah, and learn how to just ask straightforward questions instead of this garbledy mess that I know I still
sometimes you have to do a garbledy thing, and it's not a straightforward thing. It's maybe it's leading a conversation to that particular question that you want asked.
Yeah, that's so true. I think because for my thesis, I'm the data that I'm using is data from Stream 2, which is the mapping care relations stream, and it's so many of the stream leads went in, and they're the Stream 2 leads and their team went in and did all of these interviews with staff and with residents and family members at this memory care home. And just reading through the transcripts, I learned so much just from their interviewing style of how they sort of figure out how to, take a conversation that was about one thing and sort of, gradually, without strong arming anyone, leading to the places that were about the things they were interested in. So, yes, such a skill.
I was going to say that's a real skill.
Yeah.
It is. It's a learned skill. It really is. Yep. And it's the people like Jim and I and others, not so much family members, because we teach them how to do it rather than have an argument with their loved one and try and strong arm them into doing something that they don't want to do.
Yeah.
But lead them, show them how to lead that person, that loved one, to a place where they want them to be.
Yeah, and keeping people, not having this sort of top-down hierarchy of, just because this person has dementia and this person doesn't, that I'm going to tell you what to do, and you don't have any choice in the matter, or any sort of your own agency and citizenship still.
Yeah, don't take the control away from the person with dementia. Let them feel that they have control, even though they might not have all the control. But let them feel like they do, because that validates their living and breathing.
Yeah, and I know if I was in, if I was living in a facility, or if I was, was in some situation where I had less control over my day to day, I would want to feel like I had as much independence and as much, dignity and agency over my life as possible. So why would that be different from anyone else?
You'd also like to feel that you had a purpose.
Yeah.
So that you were being seen and acknowledged in that long-term care home. That you were being encouraged to participate and do things rather than just sit around and look at the TV or do nothing or sit by the wall. And that's where it becomes, the role of the recreation person in long-term care becomes important. Whereas a lot of long-term care homes don't see that value. They see it as a nice to have, but if it's not available, it's not available.
Yeah.
Certainly where my mother was, and she had Alzheimer's as well, but where my mother was, the recreation person went on sick leave and was away for 6 months, and they didn't replace her. Like it doesn't matter. And when in fact, that's a very important role.
Yeah, absolutely. The same thing actually happened in the data for the thesis data that I was referring to. The period of time that the researchers were there was when the rec person was on sick leave, and they hadn't replaced her. And I was talking to Dr. Albrecht, to Katie, about my results, and kind of saying like, oh well, they were trying to, sometimes some family members helped, and sometimes the management would jump in. And she was like, Marco, you have to think about, like, for people, you have a memory care facility full of people living with dementia who really rely on this rec program to get them up and going and feeling like they have some purpose in their day to day. And that's a really, really vital and important thing to have. So even for it to be 3 weeks where they don't have that, that's going to make a big difference in people's quality of life.
That's right.
Yeah.
And the other thing about that rec person, and it doesn't matter if it's a rec person or somebody that's jumping in to cover for them, is to treat people as individuals and respect their likes and dislikes. And just because it's Tuesday and it's bingo Tuesday doesn't mean you have to play bingo if you hate bingo.
Yeah, I'm not going to drag you out of your room to play bingo, and maybe someone is happier sitting in front of the window for a while, or
exactly
talking to a different staff member or something, right?
And that's about building those relationships and getting to know the I guess the term is resident.
Yes.
I wish
it varies. I know BC's
we're not patients, we're not residents, we're not clients.
People.
People, yeah.
Yeah, we're people. And we're all individual.
Yeah. And I think that's what person-centered care is trying to get at, but within the larger system, it's, there's roadblocks.
It's hard. It's hard. But people have to recognize that the individual has their own likes and dislikes. And I mean, the same goes for dietary.
Yeah, food is such a big thing that I think all of us who've sat around the table with Stream 2 folks will hear about the food and how important food is in long-term care. And yeah, it's such a big part of our identities is eating and the types of foods that we like and what we don't like. And not having food that you don't like for a long period of time, I know would not be I would not be a happy camper. What are some of the things that you two learned during your time on the advisory board about long-term care that maybe you didn't know before, or something that surprised you or changed your perceptions?
One of my big takeaways was from Matthias. And he was talking about restrictions and how people would get tied in years ago would get tied in a chair, and they couldn't move anywhere, and then he said there's all kinds of other ones. Now, I worked in the medical field for a number of years, and I would see what he was talking about. And let me go back and say what he was talking about now. He would say, if the bed is against the wall and you put up the rail for safety, that person is still tied into the bed. They're still restricted. And I had never thought about it that way. I thought about it as a safety thing, but not a restrictive thing. But somebody with Alzheimer's doesn't see it as safety. They see it as restrictive. And the first thing they want to do then is crawl out.
Yeah.
And
my mother did.
Yeah, my grandfather did too.
Yep.
And
climbed over the safety rail.
Yeah.
Oh my gosh.
Probably broke a hip at the same time.
No, she was lucky. Even though she had osteoporosis, she didn't. But yeah, I mean, they find a way.
Yeah. Yeah. They felt confined and almost like you were in a jail cell.
Yep.
But I had never thought about it that way.
No, I wouldn't have thought of that example either, but it makes sense. I mean, it'd be confusing if you woke up and realized you couldn't get out of your bed for some reason when you're used to being able to do that.
Yeah. So that was one of my big aha moments. And it made me look at other things that were going on within long-term care facilities that I guess I had just taken for granted because that's the way they do things and this is the way it goes. And then my eyes got opened up to other possibilities.
Yeah, when you stop sort of just thinking like, oh, well, that's, it's a medical institution, so that's how things need to work, and that's how, the authority says they need to be, then you don't question them until,
But it shouldn't be.
Oh, Marco.
Long-term care shouldn't be a medical institution.
Exactly. Yeah, exactly.
That's right.
Be the home away from home.
That's right.
And the newer ones are going more to that concept, that cottagey feeling where the people in that particular cottage become like a family, as opposed to two people who don't know each other and can't get along in sharing a room and everybody lined up in the hall, for the morning or the afternoon, and then going to bingo on Tuesdays.
So much of discussions around dementia emphasize the medical aspect. I call it the medicalization of dementia, but and that's where, and that's what I keep trying to come away or put a line down and say, no, like we're more than going to a doctor. We're more than being a patient. And that's why words matter. I'm not a patient. I'm a person living with dementia. And I'm also, like you, as you said early in this call, talked about the facility. No, it's not a facility. It's a long-term care home or long-term care residence, whatever. Because as soon as you call it a facility, a hospital is a facility. A prison is a facility, but long-term care, some people may think of long-term care as being prison, but it's a home, and you want to think of people with dementia, whether being in long-term care or not, but think of them as people, as still people who are able to still participate in their own way at whatever point they are in their journey.
Yeah, that's such a good point. And I know that the language is definitely something that I need to work more on, but it's such an important distinction to call it a home and to say that the people living there are people rather than, thinking of it as maybe what it was viewed as in the past.
As patients.
Yeah, patients in a hospital. It's not what it is now.
Yeah, it's a very complex place because it's a home for residents. It's where people live. And there's also, like there's healthcare services being provided. So, and over time, we've seen this model change to be more person-centered and make it more home-like from going to an institution. It's just, there's a lot of changes that have happened and still need to happen. And it's hard to draw that line. Same as you were saying earlier, Faye, between the quality of life of a person and their independence, and then the safety and risk, and how do we balance those two, right? They're just difficult questions that,
Yeah. And no matter what stage a person is in their dementia journey, they're still that same person.
Mm-hmm.
And, we have to give them dignity, and we have to make them feel useful.
Mm-hmm.
And even if they can't do a whole lot, there are still some things that they can do.
Mm-hmm.
Mm-hmm.
Yeah, and you'll never know until you give people the opportunity, right?
That's right.
Yeah, and everyone is different.
Yeah.
Yeah. Some people want to contribute and others don't.
Mm-hmm.
Exactly.
But Emily, you were saying that like in long-term care, medical services are provided.
Mm-hmm.
And, to a degree, I would agree with you, but there's also to a degree I wouldn't, because many people in long-term care are there not really getting medical services beyond providing the pills, but find they're probably not being able to toilet themselves without protection, but that's not a medical solution. That's, I don't know what you would call it, but it's not like a nurse is not being required to clean up type thing. Mm-hmm. And so, when I think of my mother, I mean, she was there because that's where she needed to be, but was getting no real medical service other than getting her pills given to her.
Yeah, you're absolutely correct. I completely kind of glazed over and missed that point. The activities of daily living, so like the bathing and the getting dressed and getting help with that, like that sort of assistance. You're right, and there's a lot. Yeah,
but it's. I agree with you, Jim. It's not. They don't provide a lot of medical stuff. They might take your blood pressure or your blood sugar or whatever and keep that monitored. But if you require a doctor, the first thing they do is call an ambulance and send you off to the emerge department.
Mm-hmm. Yeah.
Plus, there again, checking your blood sugar or taking your blood pressure, I mean, you can do that at home. So again, that's not providing extraordinary medical service.
But that's what the doctor comes in for once a week.
Sure.
To check that sort of stuff. And if you fall and cut yourself and require 2 stitches, you're off to emerge in an ambulance. Where stuff like that could be done in the home.
Yeah, that's very true. And those emergency trips, I know, can be, quite disruptive. Yeah, and traumatic for people. Yeah.
I mean, if you sat outside a long-term care facility and just watch the number of ambulances each day that come and go, you'd be amazed.
I was volunteering at a local facility before the pandemic, and it was like I couldn't walk in and out of the building without having to pass by an ambulance at least once a day, for sure.
And the bigger the facility, the more ambulances.
Yeah.
And that's hard on our healthcare system that everybody requires.
Mm-hmm. Yeah, absolutely. Jim, what about you in terms of things that surprised you or things that you didn't know before you joined the advisory committee that you learned from the Salty Project?
I am drawing a blank.
That's okay.
Faye is amazing how she remembers some of this stuff. But I guess to a degree, because my mother was in long-term care, and then my mother-in-law, who did not have dementia, was also in long-term care. They were in the same place actually, and they sort of overlapped a bit. I had a lot of experiences with seeing some of the things to do and some of the things not to do. So I feel that that's a lot of what I brought to the salty table. But things like, a person with dementia going up to the nursing station and saying, I can't remember where my room is, or room number is, and the care aide wheels around from what she was doing, and she says, oh, just take your age and double it. Something stupid like that. The woman is far along in her journey. She doesn't have a clue how old she is. Plus, really her room number was 99, and so you can't take your age and double it. And putting down a meal in front of the same person actually with dementia, and it was just so many colors. You could see her eyes bug out, and so she immediately pushed it away. And so I mentioned that to the care aide, maybe she'd be better with sandwiches, and the care aide said, the meal is following the Canada Food Guide. She has to learn to eat that. Sure, she's going to at her age. Like some of the, you want to say, just sort of, let's examine what you just said and see how much sense it really makes. But so lots of positive experiences.
It's such a good point that there needs to be some willingness to sort of, if the home has some flexibility in terms of taking those sorts of suggestions and being able to make those decisions together with the person living there and with their family members about how to make the day-to-day just a little bit more pleasant.
But how to provide care or attention that's appropriate. How to provide food that's appropriate, or when somebody says they're lost, help them.
Yeah, exactly.
Don't be flippant. I mean, it's one thing to say something like that to a teenager or whatever, but don't be flippant, because you're just going to confuse that individual even more. You might, once you've said that, the other care aide might say, come on, let's go to your room. But it's that flippant point that is in that person's head, and they're going, what the hell just happened? So why are you doing that?
The communication thing is such an important
piece. It really is. It can make all the difference in the world.
And you were saying that, I forget if it was Jim or Faye, were saying that you work with family members sometimes to sort of help them learn to communicate more effectively? Okay, yeah. What does that look like for you?
It's quite a surprise for them, actually. Suppose, for example, you wanted to take your loved one outside for a drive, and they said, no, I don't want to go outside. I don't want to go for a drive. Well, turn that conversation around, repeat what they've said. Okay, you don't want to go for a drive, that's fine. And then start turning it around. Did you see the bird outside that window? And go to the window and look for the bird. And talk about the bird. And again, repeat what that person has said. And that, well, maybe we should go outside and see if the bird is still at the feeder. Well, now you've got them outside because they think they want to go outside. Where 10 minutes ago they said, no, I don't want to go outside. So it's about how to turn their mindset to where you want it to be without them thinking they've lost control.
Right.
The easiest
They still want to have that control. No, I don't want to go outside. But if you change the conversation, but keep it going in the direction that you want, you're going to change their mindset too. Do you agree with that, Jim?
Pardon me?
Do you agree with that?
Yeah, I think because the thing that you will more often hear is no, because like it's going out, or it's doing something different, or it's a protective thing.
Yeah,
and so you just adjust your thinking, adjust the way you're bringing up the topic, and then moving on from there. And in some cases, they truly mean no, but in our case, I would venture to say no does not always mean no. It's how it's processed in the mind, and so it's not necessarily the best, more relevant example, but there was a woman, the wife of a man with Alzheimer's. He had been in the mall on his own, and he had come out to be picked up by her. So she drove up and, put the window down, said, come on, George, hop in. And he said, no, I can't go with you. I'm waiting for my wife. And so she said, oh, okay, that's fine. So she drove out, went around the block, came back and said, okay, come on. And he hopped in. And so it's don't be confrontational.
Yeah.
Don't challenge. Just work with what you got.
Yeah, if you're confrontational and you challenge, it's just going to lead to an argument.
That's right.
And then they're going to be called stubborn old fools, and hard to get along with.
Yep.
Yeah.
And that's going to be charted.
Yeah.
And then everybody who reads that chart has that opinion of that person.
You're a marked person.
Pardon me?
You're a marked man,
Exactly.
Yep.
Yeah, it's this pathologizing of, sort of normal responses that, most people would have if they're being, feeling attacked.
That's right.
Yeah. When the original question might not be comprehended in the right way.
That's right.
It
might not have been well understood, or it might have been couched along with other words, too many words that got the person confused.
Yeah.
So rather than saying, pardon me, could you repeat the question or whatever, it's just no. And then if there's backlash, then it's put on you as the person with dementia, when in fact, really it belongs on the other individual.
Yeah.
Do you think there are things that that long-term care homes could be doing to better support family members who are coming in and visiting someone living with dementia to communicate better, to have better relationships when they're living in that setting?
I'm not sure that I would put the onus on the long-term care home.
That's fair.
If I were to suggest anything, it would be more the creating the environment where the person, the resident, is again not just sitting by the wall, so that there has been activity, there has been involvement, there has been things happening, so that when the family member visits, not only can there be the conversation about what's happening with that family member or the traffic getting to see the resident or whatever. It can also be, I understand you did this morning, or, did you have fun at bingo? Or, it's just creating a more uplifting environment, rather than putting the onus on them on how to make the visit better. It's just creating a better environment, and a more positive environment, a more inclusive environment. And I think that would go a long way to help the quality of life for the resident, but also that would be reflected just generally with that individual. That's such a good response, and you're writing my thesis for me, Jim. But that's that is really kind of what I found in my data, was that it seemed to me such a big aspect that the families that were coming in and maintaining those relationships with someone who was living there, they felt as if this was a place that they could come in, and there's so much about what they're not talking about, in terms of not feeling like they weren't welcomed by the staff, or feeling like they had nowhere to sit, or that it was a really ugly environment or something like that. That it felt like a place where they could come and just have an interaction together. Yeah. And there was, And so I guess I'm going to be co-author, am I, Marco? I will definitely add you into my acknowledgements at the very least, Jim.
And I think those family staff relationships have to start prior to the person moving in to the nursing home. When you go, to the long-term care home, when your family goes to view the place and see what it's like, that's when you should start, and include things like, she hates peas, don't give her peas. She doesn't like this kind of music. She likes to have a nap in the afternoon. She hates wearing pants. She'd sooner wear dresses. And let them get to know that future resident, and then keep up that conversation on a regular basis, not just when there's a problem, but on a regular basis. So if you pop in, say, how's mom doing today? And it doesn't have to be a long meeting. It can be just, everything's great. She had a great time, and.
Yeah, and you're going to feel, I can just imagine from the perspective of family, you're going to feel more like you can be at ease and have a nice time just spending time with the person, if you're not worried about, okay, did XYZ happen? Do I trust what's going on in this place with the staff and the management?
Yeah. Marco, how would you and Emily feel if you walked into a classroom and nobody spoke to you?
Not good. Not good.
Very awkward.
Yeah.
It would be very awkward, right?
Mm-hmm.
Yeah. And you would wonder if you did something wrong, or if something wrong happened. Mm-hmm. And that's the same way a family member would feel when they walk into a long-term care facility and not be spoken to, and not have that relationship continue to grow.
Mm-hmm. Yeah, you don't want to feel like you don't belong there when your family member's there.
Yeah, I was just gonna say, even as a volunteer, there were some floors I would go to where the staff would, and I understand they're busy, and I'm another person coming through in the day, but some people would be really welcoming, like, oh, who are you seeing today? And I would chat with them, and that would feel really good. Whereas sometimes I would go to a floor and it was just clear that the vibe was not one where I felt particularly welcome. It just felt awkward.
But that's what some residents talk about, how they feel not seen, because they are walking in the hall and the staff person just walks by them as if they aren't there, and that, there's nothing positive about that.
No.
A lady that I know that went into long-term care just in the fall, I guess it was. She's celiac and can't eat anything with wheat or whatever. Dietary knows this, and she has not yet had a piece of bread or a piece of toast, or she's given the same food as everybody else. So on nights when they have macaroni and cheese, she has no supper.
Wow.
Yeah.
And the family's spoken with the home and everything else, and nothing's done. She hates it. And with COVID, there's no visitations, there's no anything, and she feels so alone and deserted and hungry and everything else.
It's like, yeah, that's a human rights issue, like someone needs to be fed. Like, that's such a bare minimum thing that most of us get to take for granted in our day-to-day lives. But like the fact that even hearing that story, my brain goes, well, it's really sad, but it's not the most out of the ordinary to hear something like that, which is a problem.
And that's the sad part about it,
right? Yeah. Like that should be a huge alarm bell to all of us hearing that. And
what if you were a diabetic and they kept feeding you cakes and pies?
And it sounds like, to me, I hear like it's not just someone's made a mistake. It's like there's probably some sort of staffing resource issue, or there's something going on at that organization that something like that is slipping through the cracks,
or is being allowed.
Yeah, that's the point, Jim, that it is being allowed.
That's right. So you look at the staff on the floor, the nurse or the LPN, and like, where are you? You should be the one that's raising the flag and saying this just can't go on.
Yeah. Well, she's got the medical issues charted and everything else. So, and they've spoken to everybody that they can speak to, and still nothing is being done. She asked for a second cup of coffee at breakfast last week, and she was told no, she was only allowed 1 cup.
And that's probably like supposed to be a safety issue about too much caffeine or something. And meanwhile, she's not getting her.
I don't know. Probably was decaf.
Or maybe it's a budget thing. They keep everybody to 1 cup of coffee.
Yeah, and that's probably what it is.
Yeah.
And yet you pay big bucks to have a room there.
Yep. And there we go. There's another podcast.
It's true. It's truly something that we could just talk about for days and days and days. But we have hit close to an hour mark here. Was there any final last words that either of you wanted to parlay to our audience?
I just I'm hopeful that this podcast and other podcasts do get people to think about words, to think about long-term care, to think about people with dementia in long-term care, and how they should be seen as people who are still here and can and should be expected to live a quality of life. So that would be, that's my message a lot, and is let's just, change the vision, change the attitude, and see people for who they are as individuals. So I really appreciate the opportunity of being invited to be a part of this.
Thank you so much.
Yeah, we appreciate your time and all of your insights and your willingness to share.
Yeah, Jim, I agree with what you said. And I just hope that families of loved ones in long-term care and staff in long-term care remember that the person that they see is still the person that they were years and years ago. They still have the same feelings. They just can't communicate those as well. And maybe this is you don't know what another person feels like until you walk 10 miles in their shoes. So if they're having a bad experience, I would like to see the staff on the other side of the coin. And then they would know how it felt.
A little perspective taking for everyone.
So Marco and Emily, I want to thank you for inviting me to talk today and share my perspectives. I wish you well in your studies and your theses and everything. And maybe this podcast will take the roof off the house.
Well, thank you so much to both of you. You're both brilliant advocates and speakers, and we so appreciate your time, and I'm sure our listeners will as well. So thank you so much for joining us today, and that wraps up another episode of our podcast. Thank you for listening, everyone. Thanks for joining us for this episode of Let's Talk Care. This show is sponsored and produced by Salty, Seniors Adding Life to Years, a research project aimed at improving quality of life at the end of life in long-term care. Make sure to visit our website at saltyltc.ca for more information about the Salty project, and follow us on Twitter at salty_LTC so you don't miss our next show. Show.